Ladies and gentlemen, good evening. It's a pleasure to welcome you to our tonight's event here in the lecture room of the Library of Psychoanalysis in the Sigmund Freud Museum. And I would like to extend a very warm welcome to our panelists tonight, to Richard Lane, Hanna Levenson, and Stephan Doering. The title of our panel discussion tonight, as you can read here also, Transference and the Corrective Emotional Relationship, New Perspective on the Change Process. Before I leave the floor to our panelists, I would like to say thank you to Richard Lane and then briefly introduce the panelists. Thank you, Richard, for organizing this event, and thank you for all your commitment to psychoanalysis plus research. Richard Lane, professor for psychiatry, psychology, and neuroscience at the University of Arizona, is our Fulbright Freud Visiting Lecturer of Psychoanalysis 2023. Since 1999 already, the Sigmund Freud Foundation and the Austrian Fulbright Commission, and I would like to say hello to Franziska Brunner from the Fulbright Commission Austria, invite American academics for a study visit. Since then, more than 20 American scholars, let's call them Freud scholars, have been coming to Vienna for one academic semester to do research related to psychoanalysis. The fellowship includes teaching at one department of the university. Richard Lane's course was entitled Memory, Emotion, and the Neuroscience of Enduring Change, Implications for Psychoanalysis, and also delivering a public lecture at the Sigmund Freud Museum. Let me tell you that tonight it's already Richard Lane's second lecture here in the Freud Museum. I mention this because I think it's so symptomatic for the incredible scientific activity that you, Richard, performed during these last 4 months. In addition to the course and lecture series at the Medical University, at the Department of Psychotherapy and Psychoanalysis, and in addition to the 2 events here, Professor Lane delivered 13 lectures and talks in Austria, Germany, and Switzerland, and has developed 10 new collaborations. So I think that's really remarkable. Yeah, guiding themes in his research and scholarships have been the importance of integrating systems neuroscience with psychological conceptualizations and the need to bridge basis science and clinical application. He has written more than 200 papers and book chapters. Honors include being president of the American Psychosomatic Society in 2006, a distinguished life fellow of the American Psychiatric Association, and an honorary fellow of the American College of Psychoanalysts. Then I would like to welcome Hanna Levenson, who is a professor of psychology at the Wright Institute in Berkeley. In addition to that, she maintains a private practice where she sees individuals and couples, and she is a certified EFT, emotionally focused therapy supervisor and therapist. Professor Levenson has been specializing in the area of brief psychotherapy as a clinician, as a teacher, and a researcher for over 45 years. She's the author of over 85 professional papers and 3 books. She is also a fellow of the Society for the Advancement of Psychotherapy, Division 29 of the American Psychological Association, and she has also received the Distinguished Contribution to Psychology as a Profession Award given by the California Psychological Association. Thank you so much, Hanna, for joining us tonight. So, and then last but not least, I would like to introduce Professor Stephan Doering, who is a psychiatrist and psychoanalyst. He's chair and professor of psychoanalysis and psychotherapy and head of the Department of Psychoanalysis and Psychotherapy at the Medical University of Vienna. His main research interests are psychotherapy research, diagnosis and treatment of personality disorders, and psychosomatic medicines. He's editor and co-editor of 4 scientific journals and member of numerous scientific associations. Moreover, he has received 5 scientific awards. He was the president of the ESSPD, that's the European Society for the Study of Personality Disorders, from 2018 to 2020, and he's the vice president of the GPS, that's the German Society for Research and Treatment of Personality Disorders. And he is the past president of the ISTFP, the International Society for Transference-Focused Psychotherapy. Thank you so much. We will now have 3 different presentations, then a discussion on the podium, and then we would like to ask you to join us for your questions. I wish all of you a very inspiring and interesting discussion. Thank you.
Thank you very much, Daniela. It's really such an honor to have been here for 4 months and to be here tonight. There's so many people I want to thank. Daniela and Monica, who are directors of the Freud Museum, who've been wonderful hosts. Stephan Doering has just really been an incredible academic host and collaborator. And I've learned so much from him, and it's been such a fruitful exchange, and I just can't thank you enough. And of course, Fulbright. Franziska Brunner and Mitch Sims are here from Fulbright, Austria, and it's been, the honor of a lifetime, really, to come here representing the United States as an academic ambassador. And Fulbright alone is a tremendous honor. Having this fellowship here at the Sigmund Freud Museum just made it kind of irresistible. And it's just been an incredibly productive time. I knew from the first moment before we came that every moment would be precious, and so we've made the most of it, and it's really been wonderful, and it's very sad that it's coming to an end. But fortunately, we've made good friends and established some excellent collaborations, and we're even coming back for a brief time in October, but hopefully many more visits to come. And I want to also thank the University of Arizona for their support, because they really made it possible for both Karen and I to come. So thanks to all of you. All right, so the title of this talk and panel discussion tonight involves transference and the corrective of emotional relationships. So I thought it would be useful to try to briefly mention what transference is and how it connects to corrective relationships. So I thought I'd start by mentioning some unique aspects of psychoanalysis that set it apart from other psychotherapy modalities. So first of all, there's an emphasis on unconscious processes, unconscious thoughts and feelings, and in particular, the idea that the dynamic unconscious, that these are things that were previously conscious but are kept in the unconscious because they're unacceptable. Okay, so that's one foundational idea. A second foundational idea is that childhood development plays a critical role in the problems that people have in adulthood. It's the source of unconscious conflicts that persist and cause problems later in life. And then there's a transference, which is extremely important, because the idea is that these conflicts from childhood get reactivated and get resolved in the transference relationship with the analyst. Okay, so what is transference? Raise your hands. How many people know what transference is? Most people, good. Okay. So it's the projection of unconscious feelings onto the therapist that were originally directed to important figures in childhood. Certain kinds of recurrent emotional problems in adulthood can be traced to these unconscious memories and feelings from childhood. And these problems traditionally get resolved within the transference relationship through interpretation, that is, making the unconscious conscious by virtue of insight. And a newer view is that it's not insight per se, but rather emotional interactions in the transference relationship that make the biggest difference. So this idea is one that's been around for a good 30, 35 years, captured by this quote that came out almost 25 years ago. Psychoanalysis is more than the creation of a narrative, which would be the result of insight. It's the active construction of a new way of experiencing self with other. Okay, so that idea has been around. But we're putting a particular focus on it involving emotion, which I'll describe. But what really makes this different is that we feel like we're adding some neurobiological underpinnings to this perspective. And in fact, this is a realization of Freud's dream of a brain-based understanding of mind. And that's really been kind of the kind of foundational idea that is the basis for my fellowship, that we're going to be presenting new neuroscience and how relevant it is to psychoanalysis and how traditional concepts can be updated and maybe tweaked a little by virtue of this neuroscientific understanding. So Freud said that biology is truly a land of unlimited possibilities. We may expect it to give us the most surprising information, and we cannot guess what answers it will return in a few dozen years to the questions we have put to it. And so it took more than a few dozen years for this major idea about memory to come to fruition. But the key point here is that he really thought that if we understood neurobiology, it would change our psychological thinking. And so it was in 1896 that Freud described what we now call memory reconsolidation. He called it memory retranscription. And he was the very first person to describe that, the idea that memory kind of gets rewritten as a result of new experiences. Okay. And Freud, of course, thought that, as we all do, that the purpose of memory is to create a record of the past. And now we appreciate that it's very important because it provides a guide to the future, and we understand the brain as a predictive organ, and that it all becomes very relevant to modern neuroscience. So we wrote this paper, my colleagues and I, at the University of Arizona, and Lee Ryan and Lynn Nadell, who are memory experts, and Les Greenberg from Toronto, who created emotion-focused psychotherapy. And in this paper that we published in a leading neuroscience journal in 2015, we proposed that there was this foundational mechanism of change involving memory reconsolidation. So it was in the year 2000, over a century after Freud put the idea out there, that it was finally established that memories really can be updated. Every time you recall a memory, it goes into a labile state and can be modified based on new information that comes in at the time while the memory's in the labile state, which lasts for 4 to 6 hours. And another basic principle is that we're having new experiences all the time, and we want to convert some of those experiences to long-term memory, but we can't remember everything. But emotion is in some ways nature's way of identifying what's important. And so there's a special relationship between emotion and memory that really helps determine what we remember. And it's very important, actually, and relevant to the process of change in psychotherapy, because the idea is perhaps we can exploit this natural mechanism of memories becoming labile and updatable by emotion. Perhaps we can use that to advantage in the psychotherapy context. And this seems relevant to many different modalities. It seems especially relevant to psychoanalysis. And so once we had this paper published in 2015, we thought that, it was an important new model, and we'd only scratched the surface. So we had a conference and created a book to really elaborate on both the basic science as well as the clinical applications. And Hanna Levenson was kind enough to write the chapter on psychodynamic psychotherapy, which was a great addition to the book, along with a couple of key co-authors. Okay. So in this paper and book, we said that there are 3 essential ingredients for enduring change in psychotherapy. You have to activate old memories and old feelings with or without awareness of their connection to the past. And we added that because we think that a transference response to the therapist, where you're not really aware that you are responding to the therapist as you did to your parent. But that's an example of the memory being reactivated and, influencing what happens in the present. And it was in fact Freud's original model of change, that you have to activate old memories and the associated feelings. But we went on to say that there's more to it than that. Because of this memory reconsolidation idea, you have to engage new emotional experiences while the memories are in the labile state that change the old memories through reconsolidation by transforming and expanding emotional content. And then you have to reinforce the strength of these new memories and their semantic structures by practicing new ways of behaving and experiencing the world in a variety of contexts. So you have these experiences in therapy, but then you need to translate it to the outside world. And one of the original aspects of our 2015 paper was the integrated memory model, which says that you have these three components: episodic memories or personal experiences, emotional responses, arousal, feeling, and action, and semantic structures, generalizable knowledge, and that it's impossible to activate one without the others. Okay? And so I don't have time to go into why we concluded that, but I did that, during my 12 lectures for the course. Right? So a way of thinking about this is that we develop an internal working model of the social world, which is a kind of semantic structure, generalizable knowledge. And that working model is a distillation of different personal experiences that you have. And the ones that are emotionally salient are the ones that we remember and contribute to this generalized model, which forms our predictions going forward. Okay, so in development, the interaction between events and emotional experiences help lay down this kind of general model. Then when you get into therapy, you have your general model, which is kind of problematic and needs to be updated. So you have experiences, episodic experiences with the therapist, and if they're properly timed and emotionally laden in the right way, they can update the model, right? That's the general idea. So the emphasis on emotion that we're highlighting because of, from a neuroscience perspective, was actually recognized clinically years ago in the psychoanalytic literature in 1946. Alexander and French talked about corrective emotional experiences. They said the corrective emotional experience was the fundamental therapeutic principle of all ideological psychotherapy. In their definition, it meant to re-expose the patient under more favorable circumstances to emotional situations which he or she could not handle in the past. The patient, in order to be helped, must undergo a corrective emotional experience suitable to repair the traumatic influence of previous experiences. Intellectual insight alone is not sufficient. That was a very radical statement at the time, and in fact, it was not well received by psychoanalysts. Why was it not well received? Well, because it was thought that these corrective experiences were contrived. They're not part of the natural process, creating manufactured, unrealistic experiences. There was a de-emphasis on interpretation and insight, which was, of course, the cornerstone of treatment. It might compromise patient autonomy because the therapist was being directive in a way. And there was an unneeded emphasis on emotional experiences because clearly work in the transference was highly emotional. Okay? I would say that the emotion, and that's very true, but it's very true for activating the conflict and the problems, but it wasn't part of the thought about how you actually change the problem, which is what we're emphasizing. And another objection was that it does not adequately take into account the transference relationship with the therapist, which is absolutely critical, right? So, having heard that feedback from psychoanalysts after the paper was published, I thought, okay, corrective emotional experiences, maybe we're talking about a corrective emotional relationship, because remember, we're shifting the emphasis from, specific experiences to that working model or the schematic memory. So the corrective emotional relationship retains primary focus on the transference as the focal point of therapeutic interaction in psychoanalysis and psychodynamic psychotherapy. That's what PDT is. It bypasses the conceptual baggage of corrective emotional experiences. In other words, we're advocating this for the field of psychoanalysis. It captures and highlights abundant, relevant, implicit as well as explicit emotional processes in the therapeutic interaction. And you're going to hear much more about that from Hanna and Stephan tonight. And it provides repeated emotional responses and experiences inconsistent with expectation, while old memories and old feelings, the transference, are activated, entirely consistent with how memory reconsolidation works. So these old memories create expectations, and then when the expectations aren't met, that creates the opportunity to update them. So we can understand this within this broader context of the importance of interpersonal processes in psychodynamic psychotherapy, because the problems that lead people to start therapy to begin with start in the context of childhood relationships. And then people come in for help because they're having problems in their current relationships. And lo and behold, the problems get resolved in relationship with the therapist. And have Hanna Levenson to thank for pointing this out in her book in 1995. Working with emotion and creating corrective emotional experiences in an ongoing relationship is the key to successful treatment. So I'm just so thankful to have Hanna Levenson here, who really is my favorite psychodynamic psychotherapist in the world, I have to admit it. And it's wonderful that she's here. And I've been teaching, her model to my residents now for a number of years. And I think I hold the record for viewing the Becky tape the most times, right? It's like 6 or 8 times at this point. So time-limited dynamic psychotherapy involves, treatment that might be completed within 15 or 20 sessions. At the other end of the continuum, we have psychoanalysis, which may be 4 or 5 times a week for 4 or 5 years. I would say they all involve a recurrent maladaptive pattern. They all involve updating implicit learning with contradictory information for the better. They all involve transforming intolerable into tolerable distress, and they all involve applying transformative experiences in therapy to the external world. We think that more intensive, longer duration treatment is needed with patients who have had early trauma, where they're lacking trust, and where they have impaired capacity for self-regulation. So that completes my introduction to this panel, and it's now my great pleasure to invite Hanna to come to the podium. Thank you.
While that's being set up, let me thank Monica Peltzler and Daniela Finzi for inviting me, and for Richard's generosity in sharing this amazing room with me. I came here first, I just finished undergraduate and had a backpack and got a Euro pass. Had to come to Vienna, had to come here. And now here I am. Wow, it's amazing. So thank you so much. And so corrective emotional experiences and memory reconsolidation. And I'm going to speak very little because I want to save time for lots of video, and I've only got 20 minutes, so we'll see how it goes. Thank you. This is from the bookstore downstairs. It's not easy to deal scientifically with feelings. Indeed. So I'm going to make the case that the procedure for memory reconsolidation is compatible with the strategies, interventions, and theories of contemporary psychodynamic psychotherapy, especially the concept, as Richard has pointed out, of the corrective emotional experience. And I'm going to suggest that therapists might use a memory reconsolidation framework intentionally to foster enduring change more effectively and efficiently. So with regard to the quote from Alexander in French, which Richard gave, I'll summarize to say only the actual experiencing of a new outcome, an outcome that was the exact opposite of the client's expectation, could induce the patient to give up old patterns. And how similar that is to how Richard frames memory reconsolidation. What appears essential is the juxtaposition of maladaptive emotional reactions and expectations with the novel response of the therapist, leading to a new emotional experience that is then incorporated into the existing memory structure, particularly when the old memory is activated. And such events, these corrective experiences, are not just typical helping events. They are surprising or disconfirming of past experiences, and they have a profound effect. And in interpersonal therapies, they are considered to be the core relational factor for change. I'm going to present video that I think will illustrate 3 types of corrective emotional experiences or memory reconsolidation. Number 1, when the corrective experience, memory reconsolidation, happens implicitly via novel experiences in the transference. 2, when the corrective experience happens explicitly via new non-transferential novel information. And 3, when the corrective experience, memory reconsolidation, happens interoceptively via a new sense of one's own internal state. And I'm going to use time-limited dynamic psychotherapy as a model. And this model can be applied if you're seeing someone for 20 sessions, but I use the same model if I'm seeing someone for 20 years. In short, it combines psychodynamic, relational, emotionally focused, attachment-based, experiential framework to achieve fundamental changes in intrapsychic and interpersonal functioning. It's truly an integrative model. And how do we get a focus? We use the cyclical maladaptive pattern, which is just one of many ways, as Richard pointed out, to have these common negative patterns that therapists are focusing on. And in this case, the CMP takes the inflexible thoughts, feelings, wishes, and behaviors of the patient and shows how those lead to self-defeating expectations, which then give rise to and are caused by dysfunctional responses from others, leading to negative self-appraisals, inflexible behaviors, and the whole thing just starts feeding on itself. And it is bidirectional. I like this cartoon to illustrate negative self-appraisal. I think it speaks for itself. Bad dog. And the goals, we're trying to provide new experiences and new understandings, although I am privileging new experiences. So the case from which these video excerpts come is the case of Becky. This is a video that was made for the American Psychological Association's Therapy Over Time series. It's a demonstration video. It's not real therapy, but it's a demonstration video and comes close to therapy. And APA was kind enough to give the therapist who did this series 6 sessions. So we didn't have to jam everything into one demonstration and show everything in 45 minutes. So we had 6 sessions. And this was not meant to be a completed therapy, but I think it actually developed into that. So let's take a look at Becky's cyclical maladaptive pattern. She gives and wants something back, but she doesn't really talk openly about wanting anything or needing anything. That all gets very suppressed, very censored, because she fears if she talks about what she needs and wants, others will leave her. And in fact, others do take advantage of her. Her boyfriend, that she talks a lot about and you'll hear about, really likes that she tries to please him. And if we look at past significant others, her mother, who was alcoholic, really depended on her young daughter to help keep her literally upright. And her father, who was very authoritarian and would shame the patient by calling her a crybaby, also needed special attention and to be pleased. And that left her feeling unlovable and unworthy. And that caused her to give and so forth. So that, in a nutshell, was Becky's cyclical maladaptive pattern, which I learned in pieces over the 6 sessions, but especially when you're working briefly, you try and get as much of that information as possible early on. Now, what would be Becky's new experience? Well, I hoped she would risk, in the process of working with me, finding her own voice, prioritizing her own feelings, expressing her needs, especially anger, prizing herself, and experiencing herself being valued in the transference and elsewhere. In other words, having a series of corrective, emotional, relational experiences. And the TLDP and the memory reconsolidation transformation sequence dovetail very nicely. Reactivate the cyclical maladaptive pattern, facilitate new disconfirming experiences, and repeat. And then, of course, assessing change by looking at, is there more appropriate emotion, especially when the old memory is reactivated? Is there a decrease in symptoms? Is there new insight, new understandings, new behaviors in and out of the session, a fuller experience of the self, and a shift in the therapist's countertransference and reenactments with the patient? So I'm going to begin by showing an excerpt from session 4. But before I do, let me just say that when Becky first came in the first session, she was all smiles and bubbly, and I just want to see how this whole therapy thing works. And I'm thinking to myself, oh dear, I need a patient who's got a problem here for this, 6 sessions I'm supposed to be doing for the APA demonstration series. Is this going to work? But it didn't take long with my attuning to her emotional, real torture that she was going through, but keeping it so secret, so suppressed, where she would begin then to reveal emotionally some of this torment she was experiencing. So here we are in session 4. You'll notice that I'm going to be focusing here on helping her have a new sense of an internal state, her own internal state. This maybe won't look anything like psychodynamic psychotherapy because I've really infused more traditional strategies with emotion. So let's take a look. So I'm helping the patient here interoceptively to enable a new awareness of her internal state, her CMP, the same old story is I'm a crybaby. New information, it's screaming it. I can't keep doing this anymore. Information coming from emotion. Not a crybaby, but the crying is a signal that something needs to change. It's leading the way. In the 5th session, I asked Becky to say, I am a valuable person I do this as an old Gestalt technique, but I do this to try and help her own what I think has been an evolution where she is getting more and more and more comfortable on an emotional level with the idea that she maybe has some worth. So let's see how it goes. Am I valuable enough to do so? And this will be the last request. All right, so in this excerpt, you really saw me doing several things. First of all, I presented new information non-transferentially, the CMP, in truth, I'm not a valuable person. And I then kind of, some psychoeducation, you have internalized negative messages from others as though they were true. But she's in that heightened emotional state when she hears that. And then secondly, I'm presenting new information transferentially in the relationship. In truth, I'm not a valuable person. And the new information, you have let down your wall in here and let me see who you are, and I love you. So those are my remarks. I'll just leave you with this one tantalizing picture. Becky, 5 years later. Thank you very much.
So good evening to everybody, and thank you so much also from my side for your invitation, Monika and Daniela, and of course for your great preparation of this last event of yours in Vienna. I'm really happy. It's the last event for the summer term, let's put it this way. So there is not much to add, because I couldn't agree more with what you said, and I definitely can't add anything that's coming close to this video we have seen, because it was so impressive. What I will try is to give you some psychoanalytic ideas how to understand what was going on here, what Richard was talking about, from a slightly different perspective, although I think I'm repeating many things of what you said before. You have been talking about transference already, Richard. In the very beginning of psychoanalysis, Freud discovered the transference and described it as a replacement of some earlier person by the person of the physician. And first, in the beginning, he felt this is an obstacle to psychoanalysis, to the treatment, and it would be better without any transference. But very soon, he discovered that transference serves as an inestimable service, because he would say it's impossible to destroy anyone in absentia or in effigie. So we need to have the relational experience in the room, in the transference. So I am playing the role of the parent, of the object from the past. I am the father now. And we reenact something that has happened in the past, and then we do have the memory activation and the emotional activation and the labile state of the internalized object relation, as we would say, of the schema of the cyclic maladaptive pattern, as you said before, that then can be changed or can be complemented, contrasted by a new relational experience. Very soon after, the countertransference was discovered. What is this? The early psychoanalysts had the experience that they reacted to the patient's transference, and quite often in a dysfunctional way. Probably all of you know this love relationship of Carl Gustav Jung with his patient Sabina Spielrein that took place 2 years after they ended psychoanalytic treatment. That was quite entangled and quite difficult for both of them. And after this, Freud, for the first time in a letter to Jung, described or used the term countertransference. And he said, this is really a bad thing. You shall recognize your countertransference and overcome it. And this is when training analysis was invented for the first time. So first Freud said, do self-analysis like he himself did. And then this was, because Jung suggested it, it was switched to training analysis, being a patient or being analyzed by an experienced psychoanalyst. But there is also another quote of Sigmund Freud's. This has not been as influential as it should have been. He said regarding countertransference, the psychoanalyst must turn his own unconscious like a receptive organ towards the transmitting unconscious of the patient. So here, in a nutshell, we have an idea that was forgotten for 35 years because all the psychoanalysts felt we should not have countertransference, and if we feel we have one, we better not talk about it because we will be sent back to training analysis, and this is not what we want to do. Somewhat later, Freud described the repetition compulsion because he discovered that patients tended to repeat early relational experiences in their actual experiences instead of remembering them. So he said the doctor, the physician, the psychoanalyst would like the patient to remember, to reflect, to understand what happened in the past, and of course change his behavior in the present. But this did not happen even if it was a dysfunctional experience. So he said there seems to be a drive, an instinct, an urge in organic life to restore an earlier state of things. And later in psychoanalysis, a second aspect was added, that the repetition is an attempt to gain mastery, like children's play, to learn something, to gain mastery in very simple activities. Here, everybody tries to turn a passive experience of the past into an active one, and to create an idea of mastery, of self-effectiveness that hasn't been there in the past. Again, let's talk about countertransference. 35 years later, the image of countertransference dramatically changed, and Paula Heimann was the first in 1950 to recognize that countertransference is the most important tool for our work. She would say there is a rapport on a deep level, an unconscious level, because between the psychoanalyst and the patient, that comes to the surface in form of the feelings of the therapist. And this is what we call countertransference. And this helps us to understand the patient. The consequence of this was to not condemn countertransference, but to welcome it. And this is what Joseph Sandler wrote about in his seminal article of 1976, when he claimed that we should develop a free-floating role responsiveness, which corresponds to the free-floating attention of the psychoanalyst. We should accept the role that the patient is unconsciously imposing on us, but of course in a controlled way, not by acting out immediately, but by opening up our internal stage for this emotional experience that the patient induces in us. And now we make use of Wilfred Bion's concepts that help us to understand what happens inside us as therapists as soon as we open up for the transference of the patient, as soon as we allow ourselves to experience our countertransference. First of all, Bion defined the so-called alpha function. He would say this is the part of the psyche that is used to change impressions, experiences, emotions, from what he called beta elements into alpha elements. So the mere experience, emotional, embodied experience, into something that can be mentalized. And the alpha function is something we as an adult person can make use of all the time, but a child is not yet able to do so. And so it's the mother's task or the parent's task to exert the alpha function to help the baby to regulate himself or herself and to grow. And he would say, to do this, the parent takes on a stance of reverie, like a dreaming state or dream-like state, just being with the baby without any thought, without any intention, without any memory, just loving the baby. And this is how the alpha function is enabled. And the third most important concept, I would say, is the concept of containment. You might have heard about this. He would say the baby projects, by means of projective identification, a part of its psyche into the mother. The mother accepts this projection and uses the dreamlike state of reverie, opens up for it, tolerates being affected by what the baby projects. Then it's modified, it's detoxified inside the mother, and the mother then gives it back to the baby. The baby reintrojects this part that now has become tolerable to the infant's psyche. And Bion would call the mother the container, and the part that is projected by the baby the contained. And then in the next paragraph he highlights the fact that the conjunction and permeation of the container and contained, that the container and contained has to be enriched by emotion to result in growth. And when disjoint or denuded of emotion, vitality is diminished, and the whole process, the two objects, the two people, approximate inanimate objects. So this sounds a little bit miraculous. I will give you an example for this. Imagine a 6-month-old baby is lying in bed, wakes up and feels hungry, starts to cry. Mother, sitting next door in another room, just hears the sound of crying, is doing her work, and thinks, oh, well, yes, it's 3 o'clock, so it's time for breastfeeding, but let me finish my job. So a few minutes, baby cries and cries and cries, and then something changes inside the baby. The baby feels some kind of panic, feels mother doesn't come, mother isn't there anymore, mother will never come again, I'm completely lost, I will have to die. So a very dramatic, deadly panic occurs in the baby. And the crying of the baby changes a little bit. And suddenly, the mother is deeply afraid and says, oh, this sounds different now. Something bad happened. Baby fell out of the bed. The baby is ill. And she is really in panic because she feels the baby might have been hurt or might have been deadly ill whatsoever. She runs into the room. She sees the baby with the red head, and she sees baby is in its bed and everything's okay. She is so relieved. She takes out the baby and says, oh, that was some kind of a panic. I was so afraid. Now we see everything's fine. Come, I'll breastfeed you and everything's okay. So the baby calms down. And now imagine the mother is severely depressed. The same situation, mother hears the crying, thinks, well, I wait a little bit. Okay, baby doesn't stop crying. Let's go there. Moves over, says, oh, baby, you're hungry. You want to eat? Okay, come on, I take you. So what will happen to the baby? Any idea? How will the baby behave? Will it be happy? Probably not. Probably it continues crying. And the first example, the baby probably stops crying. And what's the difference? The first diet was able to do or to contain what was going on, and the baby was able to reintroject because the mother could non-verbally express that she felt the panic of the baby, that she was affected by the panic, and she could convey this affection to the baby. And then she could convey, it's not that bad, everything's okay now. So we had this experience together, and now everything's okay. And in the second example, the mother was unable because she was severely depressed. She couldn't be affected by the baby's panic. She couldn't feel it herself. So she just did her job. And this did not change the baby's panic and did not detoxify the projected part of the self. And the idea of the containment is that it occurs all the time between parents and children, in couples, and of course between patients and therapists. And we would say it's the most important mechanism that occurs on the psychological interpersonal level that produces change. And I have to show you this wonderful quote by Bion, because it exemplifies in a completely different context how he would think we should behave, or we should allow for containment in the therapy. It was Grothstein, a psychoanalyst, female psychoanalyst, who had some kind of training, supervision whatsoever with Bion, and he explained something to her, and she said, "Ah, yes, I understand." And then he said, "Oh no, please, please do not understand. If you must, meta stand, para stand, circumstand, but please do not understand." And then Thomas Ogden, the author of this paper, wrote and explained this quote, that he says, "The work of understanding carries the danger of killing an experience that was once alive in an analytic situation." So we tend to say, as soon as we feel we understand, we are out of the process. So stick with this emotional relationship that takes place. Open up for the containment. Based on all these early, more or less early psychoanalytic concepts, the Boston Change Process Study Group around Daniel Stern and others dealt with the question, how does change in psychoanalysis happen? And their statement, the first statement was, we need something more than interpretation, if we understand interpretation as a verbal, cognitive explanation for what's going on. And what is it that we need? It's about implicit relational knowing that's distinct from the symbolic domain. So it's something that cannot be put into words, cannot be mentalized. It just happens beneath, before, under, around the cognitive exchange that takes place. A sterile interpretation, they would say, may have been correctly or well formulated, but it will most likely not have landed and taken root. What is needed? A moment of meeting, they would say. That's the event that rearranges implicit relational knowing for the patient and also for the analyst, if he or she is really engaged in this relationship. In the end, they would say, we need interpretation and moments of meeting. We need both, and they complement each other. They are complementary processes, and they are mutative. And we need them to change as change mechanisms in different domains of experience. Based on these few psychoanalytic ideas, I would now suggest a 5-step model of change. What do we need? How does change take place in psychoanalysis? We'll see this later again. The first and most important step, as soon as we have a treatment frame in place, an agreement about the method, the treatment, the goals, we will start with a containment. That's what we've just been talking about. What does the containment produce or change in the patient? I would say it induces a first relational experience, an experience of being tolerated. So the therapist accepts the role that's imposed to him or her by the patient and functions as a container, and the patient then unconsciously, that's an implicit experience, that's not a conscious one, it's a relief from the persecutory and destructive aspects of the self and the internalized early relationship experiences. And the experience with the therapist now is that this projected part, this destructive parent part or whatsoever, does neither destroy the therapist nor the patient, him or herself. So the early primitive destructive relationship experience now takes an alternative pathway. This is before any understanding, any words, any analysis or creating any narrative. And then we start, in psychoanalysis, we start to talk about what's going on. We address the transference, we define the roles. We talk about the dysfunctional consequences of these repetitive patterns. And then we try to understand the biographical background, these dysfunctional relational experiences. This transference work then produces a conscious experience, a conscious relational experience, the experience of being understood and of understanding. So when we, as therapists, communicate our understanding, the patient now consciously experiences a new working model of relationship. the patient makes a corrective relational experience. And the therapist's containment and understanding allows the patient to take the risk, as we have seen in the video of Hanna so wonderfully, takes the risk of integrating formally split off representations of self and others, and this would mean a change in the inner working model of relationship. And the last step that we have not seen in the videos, of course, but that takes place after a while, that the patients try to make use of what they learned in the treatment with us, with other people then outside the therapeutic relationship. I want just show you one model of Rainer Krause, an affect researcher and psychoanalyst from Germany, that I feel depicts this in a beautiful way. He would say in the very beginning of the therapeutic relationship, there is just the implicit and non-verbal realm that's activated. There are effective contagions, resonances, synchronization between therapist and patient, internal bodily emotional processes. Next step, the first iconographic representations take place, so the first images, the first symbols are created, metaphors are created and are suggested by the therapist or are brought up by the patients. And next step, they elaborate, they create a shared metaphoric world. So when we make use of the same metaphors and symbols from session to session, this ends up in the creation and the development of a narrative about the patient story. So now we are in the conscious realm. And only the very last step is the interpretation that we give a hypothesis. All this that has happened to you, that's happening in here right now, may be rooted in this and these early experiences. And you have shown this to us in a beautiful way, Hanna. So if we look at it like this, the interpretation might just be the cherry on the cake, or as I learned, you say the icing on the cake, isn't it? To conclude, before we give an interpretation in psychoanalysis, we focus on implicit processes. We open up emotionally for our countertransference. We tolerate our bodily and emotional experiences and fantasies as part of the embodied communication between the patient and us. We try internally, inside our mind, we try to symbolize these experiences and verbalize them, and we try to connect them with the embodied and the verbal communication of the patient. We open up our internal stage for the scene to take place in our fantasy before we say anything or we act anything out. Next step, we bring the affect on the table. You would say affect activation, Richard, I would say, or emotional activation. We address the patient's unconscious experience, and we have seen Hanna doing this, and the patient started to cry because she pointed at this very vulnerable experience of the patient. And then we try to verbalize the patient's unconscious experience. This is where our experience and knowledge is needed. And we try then, if we are in psychoanalysis, we would try to bring the emotional experience into the transference. So maybe the same happens in here. Maybe some of these tears are also directed towards me and our relationship in here. Then we focus the fantasies and feelings the patient develops towards us. So we create a joint emotional experience that can then, in the next step, be shared in a symbolized form. And only after this preparatory work, I would say, an interpretation can be effective. And these interpretations aim at the unconscious motives underlying the behavior that has just been observed and described in the transference, the patient's emotional experience, the patient's fantasies about us, the patient's relational experience with us in the here and now, and then the schema that's activated, that has been present and active before, and we try then to define relationships between different schemas, so one might defend against the other one. I would say, as a final statement, the interpretation consolidates the symbolization of the primary process and creates a shared narrative. And this is only possible via the corrective relational and emotional experience in the treatment. And there are different ways, and different treatments would prefer different ways to continue from here. With the Boston Change Process study group, we could say the implicit relational knowing is newly arranged on an implicit level. We don't need any spoken words, any symbolization, any interpretation. We can talk about reconsolidation of internal working models of relationship. Maybe there is some explicit part to this if we start to point at it and to find first symbols or metaphors. Then the third is working with mentalizations, so finding word symbols, metaphors, narratives for the internalized object relations there and then and here and now. And the most cognitive way to deal with these experiences is to work to develop new coping strategies. You can find all this and much more about the implicit modes of communication in the therapeutic relationship in this book that deals and focuses on these aspects. And I'm really curious how we will now find any controversies on the podium. Thank you.
Well, thanks to both of you so much. I mean, those were wonderful presentations, and I learned from both of you. And I thought that the talks went pretty well together. And I think Hanna, really emphasized what could be done, on a shorter-term basis. And I think Stephan did a beautiful job of explaining how traditional, intensive, high-frequency psychoanalysis over a period of years works. But I hope you saw that there's some common principles that bridge the different modalities. So let's open it up for questions and comments. Yes?
I have a question. I'm just curious, if you achieve or if you encourage the patient to open up like that in the therapy or accept the kind of vulnerability, how do you prepare the patient for the real life afterwards? Because in the therapy it can be like safe, but in real life she would probably face a lot of rejection. So I was just wondering, how can you prepare the patient for that?
Well, I think maybe I could repeat the question. So how do you prepare the patient for really carrying this into her life and not just having it all end when the therapy ends? I think you need to build it in. I think when Richard presented, the memory reconsolidation idea, it's that you must generalize it. You must repeat it and you must generalize it. In my work with Becky, for example, at one point I said to her, well, is there someone you could try this out with? In other words, she was always the listener and felt like no one was interested in what she wanted to say, and she just had to, give over the space to whoever was talking. And I said, well, is there someone who would be safe enough? I didn't want it to be Brian, but is there someone who could be safe enough that you could try this out with? So for me, you kind of integrate it and build it in as you're going and see then what happens. And when she brings it back and says, well, no, they rejected me, then you have that to work with in the therapy, and it's not something that would happen after the therapy was over. Does that help answer your question? Yeah.
Yeah, having seen the Becky tape, I can just say that, she recommended trying it out in a less high-stakes situation, one where she could possibly tolerate disappointment. But then when she had that success, it was very meaningful for her. So baby steps before running a marathon, I would say. Yes. Yeah. Oh, yeah.
Thank you for the very inspiring presentations, but I couldn't help to wonder or to think about conversations with colleagues coming from a cognitive behavioral therapy environment. And the discussions that we have is always like that nowadays they try to implement theories or techniques from psychodynamic therapies, and I was wondering, especially with your presentation, Professor Levenson, what would you say is the difference, apart from the theoretical framework, in the practice of psychoanalysis, psychodynamic therapy, and cognitive behavioral approaches? And what will be the differences in future? Like, what is your, what do you think about how psychoanalysis will develop in terms of practices? And yeah, it's a big question, maybe.
Yes, that we could certainly throw open to the group. I love that question. I'd love to throw that open to the group. I'll just say in passing with regard to cognitive behavioral therapy, and it's my experience that CBT finds something that it knows is good, and then like an amoeba, it surrounds it and incorporates it and claims it as CBT. So you'll find mindfulness now as CBT. You know, it's not CBT. Or you'll find schema therapy, which started off very much psychoanalytic and so forth. So now what we talk about CBT, you know, we have to be careful. Where did this come from? How did this happen? That's my private thoughts on that.
So maybe I can add, I'm absolutely convinced that effective therapists of every school will make use of these basic principles we've just been discussing. There is one, and less effective therapists of every school are just unable to do it good enough. There is one exception, I would say, if it's a very mild psychopathology. Like I remember when I had a critical accident in an airplane, I was phobic to fly for a few months, and I forced myself to go on some flights, and then this was reduced. So I can make use of skills if I'm not severely ill and change something. But if there is this severe, dramatic experience of aversive relationships or even trauma in childhood, this doesn't work. There is no skill that changes my experience. And then we need the ability of the therapist to engage in a really emotionally open relationship and to do all this containment work and to communicate like you have shown us so beautifully with the patient on an emotional and relational level. And then we cannot just talk about cognitions and actions.
Beautiful answers, and I'll just add that one of the differences between CBT and other more experiential or insight-oriented approaches is how emotion is dealt with. In CBT, emotion is treated as a symptom, for example, depression, and we try to get rid of it. Whereas in experiential modalities, psychodynamic, we go into the emotion as a mechanism of change. The second thing I'll say is that CBT prides itself on having a very sound scientific foundation, and it is well-founded in animal models of classical conditioning and operant conditioning and the like. What we're trying to do here is, and psychoanalysis has been faulted, I think rightly, for not having an adequate empirical foundation. And what we're trying to do here by bringing in neuroscience and taking these traditional concepts and reconceptualizing them from a neuroscientific perspective is to put it on a new, solid, empirically based neuroscientific foundation. There was another question over here.
I'll try out the mic, sorry. Testing? Yeah. Okay, my question is really regarding what you guys, and women, mentioned before on the high stakes controlling. So if you talk to a person, you get him to open up, especially in the the session you showed. Every individual is different with different triggers. They can be very put together. You can get them to open about one memory and everything can change. The question is, how do you assess it? How do you control it? How do you evaluate the risk factors? That's really what I'm curious about. Does it make sense?
I'm not sure what you mean by risk factors exactly. risk factors
so for example, with Becky, where you were sitting, for example, you get her to open up because she has to face herself, she has to find her self-worth, and so on. So in this case, it worked out, and I'm very happy.
Right.
But let's say, how do you evaluate whether it's the right thing to do, and how do you know that if you do that, it doesn't counter? And for example, let's take edge case. She imagines she has more self-value that she really has, and becomes toxic to the outer world. Just taking an edge case. Yeah.
Well, I think Professor Doering's containment, which I maybe translate, and I'd be interested if you think this is an apt translating. This is more effective attunement. Is apropos. So when I'm working with a patient, I'm really tracking moment by moment what's happening, right? Because it's not a one-size-fits-all by any means, right? And you see this with, parent and child, It's not about, oh, let me hold you and, hug you. It's what signals am I getting from that child about what is safe, what feels like comfort and what feels like distress, and picking that up as you approach. And I think, for example, I made a real error here about having Becky say I'm a valuable person when what came out of it was valuable, but I prematurely was pushing something that she was not ready for. And in fact, she let me know in a very heartfelt way, this is, no, I'm not worthy. I am not a valuable person. I am not there. And it's trying to, pick up that attunement so that you are not coming in and doing X, Y, and Z when it's really inappropriate. And it's very micro. It's like little mini experiments that I feel like I'm doing every, second of the therapy. What's happening with her eyes? What's happening with her body? How's her breathing doing? But all of this stuff that I'm not even tracking consciously a lot of the time, right? I don't know what.
Well, I would just add that probably you're as good as doing this as you are, because you are able to make use of your countertransference. And what the patient induces in us regarding emotions and fantasies is a key to understand the patient's internal processes. So in case Becky would have been a severely traumatized borderline patient, ready to jump out of the window in the next minute, you wouldn't have behaved in this way, but you would have done different things, because you would have felt some kind of maybe unspecific anxiety, what might go on, some threat in the room. So we have to learn to read our own reactions to the patients, and that guides us to our choice of the next intervention, I would say.
Right. And maybe also, lest people leave thinking we have to do it so perfectly. I mean, rupture repair is how good therapy happens, right? So you do something and it ruptures. Now you hope it doesn't rupture so someone's jumping out the window. But there's a rupture, and then how do you repair that? Which is often much more successful than if it would have gone well to begin with.
And I'd simply add that you just pay very careful attention to the process, and you make trial interpretations and trial interventions, trial empathic statements, and you see how the client responds. And that's really critical feedback. And you don't, try not to get too far ahead of them. And if it doesn't go well, you really notice that and take that into consideration. You repair the rupture and recalibrate. But that's why we have psychiatry residencies that last 4 years, and PhD programs and internships and postdocs for many years to learn exactly this kind of stuff. And it's hard to summarize it in just, it's a great question, and it's the correct question, but it's a hard question to answer because there's a lot that goes into it. Karen, did you want to say something?
Well, as usual, we are tracking along the same lines, because I was thinking this is the point where
I was thinking that this is the point where it would be important for people in the audience who haven't experienced training or their own therapy to maybe hear a little more about, well, how do people learn to do this? Because it kind of seems like magic. And I think there is a learning process. I know, Hanna, you've been thinking a lot about that. So that might be useful for people to get a sense of how do you learn to do this?
Well, the short answer is doing sufficient training therapy, and I would feel at least as important as receiving sufficient supervision. So do it yourself and reflect upon what's going on with an experienced person. And this is how we learn treatment, isn't it? But that's the wonderful thing of being a psychotherapist and a psychoanalyst, is that you become better the older you get. As long as you're not demented, and maybe even then, you get better, and that's why many of them, like Otto Kernberg at the age of 95, are still getting better from day to day. I feel that's a wonderful perspective for retirement.
Thank you for that.
All right. Well,
I would say this was an absolutely inspiring and instructive presentations and discussion. Thank you so much, also you, dear audience. And I thought it was just the moment to close, because so if there is no more question, I would like to say thank you again, and thank you for your work. Keep going, and the discussion will also be available on our homepage if you would like to see it again. Thank you again.